Hello, and welcome to the ASCO Daily News Podcast. I'm your host, Dr. John Sweetenham. On today's episode, we'll be discussing promising advances in newly diagnosed chronic phase CML, relapsed B-cell lymphoma, multiple myeloma, and other hematologic malignancies that were presented at the 2025 ASCO Annual Meeting. Joining me for this discussion is Dr. Marc Braunstein, a hematologist and oncologist at the NYU Perlmutter Cancer Center. Our full disclosures are available in the transcript of this episode. Marc, there were some great studies in the heme space at this year's annual meeting, and it's great to have you back on the podcast to highlight some of these advances.
Yes, I agree, John, and thank you so much for inviting me again. It's great to be here.
Let's start out with abstract number 6501. And this was a study that reported on the primary endpoint results of the phase 3B ASCO START trial, which assessed asciminib versus nilotinib in newly diagnosed chronic phase CML. And the primary endpoint of this, as you know, was time to treatment discontinuation because of adverse events. Can you give us your insights into this study?
Absolutely. So, like you mentioned, asciminib is an allosteric inhibitor of the BCR-ABL kinase that has activity in CML. And that includes patients with the 315I mutation that confers resistance to first and second generation TKIs. So the ASCO first study, which was published last year in the New England Journal of Medicine, showed superior efficacy of asciminib compared to investigator-selected first or second generation TKIs, actually leading to the FDA approval of asciminib in first-line CML. So the authors of that study presented data at this year's ASCO meeting from the phase 3 ASCO START, comparing safety and time to discontinuation due to adverse events of asciminib versus nilotinib, a second-generation TKI. So 568 patients with newly diagnosed CML were randomized 1-to-1 to once daily asciminib or twice daily nilotinib. So at a median follow-up of 9.7 months, about 11% in the asciminib group and 17% in the nilotinib group discontinued treatment, with significantly fewer discontinuations with asciminib due to adverse events. There was also a secondary endpoint of major molecular response, which was also better with asciminib. For example, the MR 4.5, which is a deep response, was 2.5 versus 0.4% favoring asciminib by week 12. So I think in conclusion, these results build on the ASCO first study, making the case for the superior safety and efficacy of asciminib versus other first or second generation TKIs in newly diagnosed CML.
Thanks, Marc. Do you think this is going to change practice?
I think so. I think there are still some questions to be answered, such as what resistance mutations occur after first-line treatment with asciminib. But I think the sum of these studies really make the case for using asciminib upfront in CML.
Okay, great. Thank you. And let's move on to our second abstract. This was abstract number 7015 and was reported from Mass General Hospital. And this was a study in patients with relapsed and refractory diffuse large B-cell lymphoma and reported the 2-year results of the so-called STARGLOW study. This is a comparison of glofitamab, a T-cell engaging bispecific antibody, with gemcitabine and oxaliplatin in this group of patients. Can you tell us a little bit about your impressions of this study?
Absolutely. So just for background, the treatment landscape for relapsed or refractory large B-cell lymphoma is expanding, now with 2 bispecific antibodies targeting CD20 that are approved after 2 or more lines of therapy. Among these, glofitamab was approved in 2023 based on phase 2 data showing an objective response rate of 52%, with 39% complete responses in relapsed refractory large B-cell lymphoma patients after a median of 3 prior lines of therapy. Distinguishing glofitamab from epcoritamab, the other approved bispecific, glofitamab was given for 12 cycles and then stopped. Additionally, when combined with gemcitabine and oxaliplatin in the phase 3 STARGLOW study, there was significantly improved overall survival compared to rituximab plus gemcitabine and oxaliplatin in transplant-ineligible relapsed refractory large B-cell lymphoma patients at a median follow-up of 11 months. The authors of that study, published last year in Lancet, now present at ASCO this year the 2-year follow-up of the STARGLOW study. 274 patients with a median of 1 prior line of therapy were randomized 2-to-1 to glofitamab plus GemOx versus rituximab plus GemOx, with the primary endpoint of overall survival. Here, the median overall survival was not reached versus 13.5 months, with a median PFS also significantly improved at about 14 months versus 4 months in the control. CRS of note in the glofitamab arm was mostly grade 1 or 2, with only about 2.3% grade 3 events, and 3 of the 4 patients had greater 1 or 2 neurotoxicity. So, John, putting this into context, I think it's encouraging that we now have randomized data showing the superiority of a bispecific plus chemotherapy over rituximab plus chemotherapy in transplant-ineligible patients. And while only 8% of the patients in the STARGLOW study had prior anti-CD19 CAR T-cell therapy, I think this regimen could be considered in those patients who are ineligible for transplant or CAR T-cell therapy.
Yeah, I agree. I think a couple of other compelling numbers to me were the fact that around 55% of these patients were alive at 2 years in the group who'd received glofitamab, and that almost 90% of those having that arm of the study who had a CR at the end of treatment were alive at 12 months. So clearly it's an active agent and also a kind of great off-the-shelf fixed duration alternative in these relapsed and refractory patients.
I agree. And I would also note that the phase 3 SkyGlow study is looking at glofitamab plus Pola-R-CHP versus Pola-R-CHP alone. So we may even be using these eventually in the first-line setting.
Absolutely. Let's stay on the theme of diffuse large B-cell lymphoma and look at one other abstract in that space, which was abstract 7000. This was a study from the HOVON group in the Netherlands, which looked at the prospective validation of end-of-treatment circulating tumor DNA in the context of a national randomized trial. What are your thoughts on this?
So non-invasive liquid biopsies to detect and monitor cancers via circulating tumor-derived DNA or ctDNA, is really emerging as a valuable tool in both solid and liquid tumors to understand disease biology and also for drug development. So to date, the most established application of ctDNA in lymphoma, I would say, is really for monitoring of minimal residual disease. So in this correlative study by Stephen Wang and colleagues in the HOVON group, they evaluated the prognostic significance of MRD status as assessed by ctDNA following first-line treatment with curative intent with either R-CHOP or dose-adjusted R-EPOCH. At the end of treatment, encouragingly, 76% of patients were MRD negative and 24% were MRD positive. Now, of note, MRD positive status at the end of treatment predicted inferior progression-free survival at 2 years, with only 28% of patients who are MRD positive being progression-free versus 88% who were MRD negative. And in fact, all the patients who failed to achieve a complete response after first-line treatment and were MRD positive ultimately relapsed. So circulating tumor cells are rarely found in large B-cell lymphomas. And so this study really builds on accumulating data that ctDNA has clinical value to detect residual disease with a non-invasive approach. So there are many implications of how we could potentially use this to detect early signs of relapse, to potentially escalate treatment for consolidation if patients remain MRD positive. So I think this will eventually become utilized in clinical practice.
Yeah, I agree. I think it's interesting that it provided an independent assessment of response, which was independent, in fact, of the results of the PET-CT scanning and so on, which I think was very interesting to me. And the authors of the abstract actually commented in their presentation that they think this should be integrated as part of the standard response assessment now for patients with large B-cell lymphoma. Would you agree with that?
I would. For one thing, it allows repeated sampling. It's a non-invasive approach. It doesn't necessarily require a bone marrow biopsy, and it may have more sensitivity than conventional response measures. So I think having a standardized system to assess ctDNA will be helpful. And definitely, I think this will be a valuable biomarker of disease response.
Okay, great. Thanks. We're going to change gear again now, and we're going to highlight two abstracts in the multiple myeloma space. The first one of these is abstract 7507. And this abstract reported on the long-term results of the CARTITUDE study for patients with relapsed and refractory multiple myeloma. What are your comments on this presentation?
So this study actually got a lot of press, and I've already had multiple patients asking me about CAR T cells as a result. Just as some background, CAR T cells targeting BCMA, which is pretty much universally expressed on malignant plasma cells in myeloma, have really shown remarkable responses, especially in heavily pretreated patients, showing superior progression-free survival in both later and earlier phases of the disease, including in randomized studies in patients with second line or beyond. So the CARTITUDE-1 was really the original phase 1/2 study of cilta-cel, one of the two approved anti-BCMA CAR T cell products, which was investigated in patients with a median of 6 to 7 prior lines of therapy. So these were patients who were pretty heavily pretreated. So in the study presented by Voorhees at this year's ASCO meeting, this was the long-term follow-up at a median of 5 years from the one-time CAR infusion in these patients with a median of 5 prior lines of therapy. And remarkably, of the 97 patients, 33% remained progression-free at 5 years plus without needing any further myeloma treatment during that time. And among those 33% of patients, 23% had high-risk cytogenetics, which we know are notoriously difficult to achieve responses in. What was interesting that they presented as correlative studies was there were some biomarkers that were distinguishing the patients who had the long PFS, including enrichment of more naive T cells in the product, lower neutrophil to T cell ratio, higher hemoglobin and platelets at baseline, and higher CAR T cell levels relative to soluble BCMA levels. And the fact that they reported a median overall survival of 61 months in these really heavily pretreated patients, I think these data are impressive. I think we're going to continue to be using CAR T even earlier in the disease status than 5th or 6th line as it was studied in CARTITUDE-1. There are even ongoing studies looking at first-line treatment with CAR T cells.
So do you think that those 33% of patients who are disease-free at 5 years, do you think any of those are cured?
That was one of the headlines in the press. I think if we're going to discuss things like operational cures where we're transforming myeloma into a chronic disease where patients can live practically a normal life expectancy, I think the measure of 5 years, especially in this population that was explored in CARTITUDE-1, I think we can call that close to a cure.
Okay. Well, thank you. Exciting data for sure. We're going to conclude today with another abstract in the multiple myeloma space. And this was abstract 7500, which looked at an MRD minimal residual disease driven strategy following induction in transplant eligible newly diagnosed multiple myeloma patients and reported on the primary endpoints of the phase 3 MIDAS trial. Can you walk us through this one, Marc?
Absolutely. It is a bit more complicated than the prior one we discussed because this is a randomized study with 4 arms. So I'll start by saying that anti-CD38 based quadruplet regimens continue to show superior outcomes in both transplant eligible and ineligible newly diagnosed multiple myeloma patients. The MIDAS study you mentioned is an open label phase 3 trial with 4 arms in transplant eligible newly diagnosed myeloma patients. And initially, these patients were all treated with quadruplet therapy with the anti-CD38 antibody isatuximab combined with carfilzomib, lenalidomide, and dexamethasone in 718 newly diagnosed myeloma patients. So they received the quadruplet regimen for 6 cycles and then were randomized based on their MRD status at 10 to the negative fifth following 6 cycles of induction. And that first randomization, if they were MRD negative, was to either consolidation with 6 more cycles of the quadruplet regimen or transplant, autologous transplant, plus 2 cycles additionally of the quadruplet regimen. And both arms were followed by lenalidomide maintenance. The primary endpoint was MRD negativity at 10 to the negative 6 prior to entering the lenalidomide maintenance component. And in addition, the patients who were MRD positive after induction were randomized to transplant plus 2 cycles of consolidation or a tandem autologous transplant. So the median follow-up of the study was about 16 months, and the pre-maintenance rate of MRD negativity was high, between 84 to 86% between the two arms who were MRD negative, which was not significantly different. And as far as the 233 patients who are MRD positive, the pre-maintenance MRD negativity was also not significantly different at 40% for those who received autologous transplant and 32% who received a tandem transplant. So there's a lot of debate in the myeloma field about the evolving role of autologous transplant and whether transplant still plays a significant role in patients who are either MRD negative after induction or who have deep remissions and are a standard risk. So I think these data suggest from the MIDAS study that patients who are MRD negative after induction with a quadruplet regimen studied here, which was ESA KRD, plus consolidation, may possibly be able to forego consolidation with autologous transplant. And likewise, for those patients who are MRD positive after induction, tandem transplant didn't seem to provide much of a benefit compared to single transplant, which is consistent with prior studies such as the Stamina study.
So where do you think this leaves us, Marc? Are we going to need more studies before we have any definitive guidance on whether an autologous transplant is still appropriate for those patients who are MRD negative?
Well, as clinicians, we want to do what's best for our patients. And in myeloma, the best we can do is to get as deep remissions as possible, meaning MRD negativity. And so I think it's clear from the MIDAS study and others that quadruplet regimens provide the deepest remissions when given upfront. We can debate the role of autologous transplant. I think certainly the role of tandem autologous transplant is fading. But as far as a single autologous transplant as consolidation, I think it's reasonable as a goal to try to achieve MRD negativity after the transplant, especially for patients who remain MRD positive after induction.
Okay, great. Marc, thanks as always for sharing your insights on the heme malignancies studies from the ASCO meeting this year and for joining us on the ASCO Daily News Podcast. Always appreciate hearing your thoughtful and balanced input on these.
My pleasure. Thank you, John.
And thank you to our listeners for joining us today. You'll find links to the abstract discussed today in the transcript of this episode. Finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.